Okay. Okay. بدي got it.
قد الموضوع شيء.
Okay.
Okay, now it shows full screen.
Very good. برات المكتب لأن مفكر إنه وقت وبعد الجيش Okay.
Okay.
Yeah, we're ready to start. Okay, I want to ask Abdullah Ali Shalil. Does he hear me, Abdullah?
موجود عبد الله يا دكتور.
بس أعطيه السبيكر. Can you describe what he sees here?
Can you describe what did you see?
دكتور جون السلام عليكم يا دكتور جون.
يا أهلا. اللي what do you see on these two X-rays?
There was X-ray of skull of children.
Hey. There's an X-ray of the skull and the thorax, including the pelvis and the hips.
Yes.
In a child that was newborn. شو بتقشع بالchest؟ طلع مثل جرس الكنيسة، مثل جرس الكنيسة. منتبه لهي؟
Yes, yes.
The ribs are horizontal. The skull is large. Look at the hips. You see that the hips are abnormal. The femur is invarus and short. When you look at this X-ray, بدي أخبركم شيء يا شباب. أنتوا كلكم رح تصيروا جراحين عظم. أوقات بيجيكم على الكلينيك صور refer to you from different places. مهم كتير إنه تاخدوا فكرة عن الديسبليسياز. شو هني؟ بس تاخدوا فكرة. ما عم نقولكم تحفظوا what are the genes وكذا. بس at least when you look at the X-rays, you can say that this is a dysplasia. And if you look at this, the X-rays, you can see that there is a severe platyspondyly. لما بنقول platyspondyly يعني بتلاقي the vertebral bodies are flat. They are spread out. And you see that there is a narrow thorax. And we call this a tent. يعني مثل الخيمة, tent-shaped thorax. And these patients are born with asphyxia. بيكون عندهم difficulty in breathing. هلا إذا بتنزلوا للبلفس بتقشعوا إنه في horizontal acetabulum و short femurs. بقى therefore بتقدروا تقولوا إنه this is a dysplasia. And شو جنسها؟ هيدي this was typically a xanthophoric dysplasia. يا حي هون xanthophoric dysplasia. ما رح بسأل الهيئة الظاهر صعب كتير عليكم. من هيك اللي في كتار ما بيحبوا هالسبجكت. بقى رح كمل أنا باللكشر الهيئة صعبة. Okay, now honey, if you look at these X-rays, look at this. Look at the hips. You see that the acetabulum is large. You see that there is some kyphosis at the thoracolumbar junction. تقشعوا الهيبس مش طبيعي. تقشعوا البلفس الإلياك كراس عريضة. تقشعوا الاسكيل tuberosities are wide. وهيدا البيشنت عنده achondroplasia. اللي بنقشع ما بيصير ما بتقشعوا منهم ماشيين على الطرقات. بيكون عندهم nasal depression, يكون عنده الفورهيد protrusion، الماندبل طالع شوي لبرا، ما بيصير ما تقشعون. هولي these patients have the most common type of skeletal dysplasia. At times you get x-rays like this. إذا بتطلعوا على الفيبولا من جهة الأنكل تقشع الفيبولا is long، تقشع الفيبولا is long، تقشع الفيمر قصيري، تقشع في funnelization of the distal femur. And this patient has hypochondrodysplasia. And if you look at the spine, ليش المرضى اللي عندهم achondroplasia or dyschondroplasia or hydrogenic plasia or hypochondroplasia تقشعوا pedicle spaces become closer، بيصير عندهم spinal stenosis باللمبر area، في منهم بينشلوا اذا ما نعمل لهم decompression. هول كمان بيكون عندهم stenosis بالاوكسيبيتو cervical region. بقى هول لازم تعرفون، لازم تعرفوا كيف هيئتهم. رح فرجيكم عده اكس رايز عليهم هلا بتقشعوهم. هون كمان بتقشعوا other patient، تطلعوا بالهيبس they are abnormal، they are flat the epiphyseal ossification center. ما فيك تقول انه هيدا عنده leg bursitis disease، لا هيدا غلط. To see leg bursitis disease you see the stages of leg bursitis disease, the stages of fragmentation. But what we know is that this patient has a dysplasia, and what he has a small epiphysis, wide femoral neck, hypoplastic iliac wings, flat epiphysis, Schmoll's nodules yani herniation of the disc within the vertebral body. So you have to know this. وإذا بتطلع بالصورة على الطرف اليمين بتلاقوا الفibula is longer than usual. It's impinging more distally on the ankle. At times it is longer proximally. These patients have dysplasia when they're born. This is another patient. طلعوا ما في اودونتويد، رايح الاودونتويد، ايش اللي عندك على الكلينيك محتار ما عنده اودونتويد. تطلع بالهيبس both hips are dislocated. تطلع بالاcetabulum they are broadly enlarged. طلعوا بالvertebral bodies، طلعوا قديش طوال بالsagittal view, and this is what we call platyspondyle. And this patient has what you call it, a typical form of Morque's, congenital. It's called spondyloepiphyseal dysplasia, congenital. It's related to the family of mucopolysaccharides. لازم تعرفون هول. هون كذلك. So I'm going to go very quickly through this. These are various patients. This is another group of patients who has chondroectodermal dysplasia. They have short ribs. When you look at these x-rays رح بتقولوا شو جايين نعمل هون نحن؟ شو جايين شو فرقان معنا؟ لا، هيدا باب المصاري. إذا بيعرفوا غير ناس إنه أنت بتعرف عنهم بيبعتوا لكم مرضى مشان to arrive at the diagnosis. And in the States, it's a part of the requirement of the American Board of Surgery to know about these things. And I'm going very quickly through this because we'll be going into each one in detail. كمان عندك some false forms of achondroplasia, and I will be going through them in detail. So I'm going to shift from this and share another lecture in the screen. I chose these as examples قبل ما نبلش. لحتى تعرفوا بأي ورطة واقعين فيها. So now I'm going to make a new share and go into this lecture. Wait one second. كيف بدنا نشيل هذه؟ ما بعرف. I'm going to go into a new chair. ما عم بقدر انقلها هلا. يا الله. يلا لقينا الحل. Okay. This is the format of the lecture that I will be giving. Okay. شايفين السكرين؟ خالد. يا خالد.
ايوه معك دكتور جون. السكرين لسه ما ظهرت.
شايف السكرين؟
لا لسه.
بعد
ايه.
يا الله.
حاول زي المره اللي فاتت.
هلا بنجرب نشوف. طيب وين النيو شير؟ ما فهمت.
لا ها بريتك ظهرت. دكتور جون. دكتور جون عشان سلام حقه. دكتور جون.
ايه سمعني؟
خلاص اي سمعك والسكرين فل الان كويسه واضحه.
Okay, good. Now this is the lecture I'll be giving. Now, all dysplasias that have an abnormal maturation of the growth plate, chondroblasts, are associated with dwarfism. انتوا بتعرفوا بالجروث بليت عندكم الريستنج زون، بعدين عندكم البروليفرتيف زون، بعدين followed by the zone of hypertrophy, and finally by the zone of provisional calcification. The zone of hypertrophy, the cartilage cells become abnormal and separated by fibroblasts and fibrous tissue. And as a result, growth is disturbed. نحن بنعرف انه في two forms of growth لازم تعرفوهم. Formation of bone. There is the endochondral bone formation and there is the membranous bone formation. المembranous bone formation بتكون من ورا البريوستيوم. Okay? الendochondral بتكون within the endosteum. And هيدي يلي is disturbed. ومشان هالسبب بصير عندك dwarfs. يعني ولاد قصار. They are short. The signs include abnormal growth in the spine and skull and in the long bones of the arms and legs, which can result in the individual being short in stature. Most of the bone dysplasias result in short stature, which is defined as a height that is less than the third percentile for the chronologic age of the patient. Yani we have special mapping, special graphs, and these children are no longer in the upper or middle percentile. They are either in the lower percentile and even less. And as a result, they can have either a proportionate or disproportionate dwarf appearance. يا الإجرين بيكونوا قصار الثوركس بيكونوا normal، يا الإجرين بيكونوا within normal but the thorax is short. The spine and everything in it is short. So you have to pay attention. And scientists nowadays عم بيبلشوا يعرفوا أي dwarf من ورا this or that form of gene abnormality. But for us, we don't need to know this. We have to know the appearance of each one. The skeletal dysplasias are an extremely heterogeneous group of conditions that affect bone development. They encompass 400 disorders, 400 disorders, and most are the result of genetic defects. Skeletal dysplasias can present any time from the prenatal period to adult life. The estimated incidence of skeletal dysplasias is approximately 15.7 in 100,000 live births. Now we come to the individual dwarfs. I have seen quite a few of dwarfs that we call diastrophic dwarfism. And you cannot miss them once you know the clinical presentation. It is an inherited condition and autosomal recessive with micromelia. What do we mean by micromelia? Micromelia means shortening of the extremity and minimal disturbance in the axial skeleton, and mainly the spine at birth, and there is a 25% chance risk of the second baby born with the same problem. مشان هيك you should know about them. بيجوا عندك الأهل، هيدا الولد تبعنا، إذا أجينا ولد تاني بيكون مثله، بدك تعرف إنه 25% are born the same. It's a mutation in the DST gene. Ignore this. On chromosome 5. Ignore this. In certain countries, they have a higher incidence than other countries. And you have to keep this in mind. How does the child look? طلعوا بهالولد. Why was he called a crooked or twisted child? By the Greeks, and they gave it the name dystrophic dwarfism, means crooked and twisted. إذا بتطلعوا بهالولد تقشعوا كتير اشياء. تقشعوا انه the humerus and the femur are much shorter than the distal bones, and this is what we call rhizomelic. وإذا بتقشعوا بالإيدين في abnormality بالthumb, and this is what we call the hitchhiker's thumb. إذا بتطلع بإجرين هالولد بتلاقي عنده severe clubfoot deformity. Now, these children, when they are born, they usually have respiratory difficulties. This is looking at the child from the front. طلعوا بالarms. The arms are short. They are shorter than the forearm. طلعوا بالthighs. They are short. طلعوا بالركاب. They are dislocated. طلعوا بالthumbs. The thumbs are perpendicular to the rest of the fingers. And this is what we call the hitchhiker's thumb. طلعوا بالبيد, بالfoot, بالإجرين. بتلاقي إنه they have a severe, rigid clubfoot deformity. I've had 3 cases in my lifetime, and I cursed the moment that they were sent to me for treatment. These patients have very rigid deformities and very difficult to correct. They have a crouched appearance. يعني crouch. Crouch يعني طابين لقدام. The hips are in flexion. The knees are in flexion. طلعوا بالthumb, بالأصبع الكبير تبع الإيد. They are perpendicular. This is a hitchhiker's deformity of the thumb. طلعوا بالvertebra بصير عندهم scoliosis. طلعوا بالhips, they are dislocated and rigid. لحتى you can see that there is hardly any acetabulum. طلعوا بالhips يكون عندهم coxavara, and you have to consider correction. This is a larger view. Shout thumb perpendicular للإيد. This is the hitchhiker's thumb. Don't forget this, please. Don't forget this. Okay? So, this is very important. طلعوا بالإجرين. They have a club foot, and they are very resistant to treatment. This is called dystrophic dwarfism. Don't forget this. إذا بتطلعوا بالدينين, they have a cystic collection بالباينة تبع الإير. They call it the cauliflower deformity of the air. You see that it's full of blood and fibrous tissue, and with aging, it becomes calcified. I repeat, this is a cauliflower deformity. This is the physician carrying the child, and the patient has a flexion contracture of the hip, a dislocated knee with a flexion contracture of the knee and with the club feet. And you can see the hand of how it's perpendicular to the rest of the fingers. These babies have a narrow nasal bridge. They have a broadened mid-nose with flared nostrils. There is a defect in synthesis of type 2 collagen. The hadal physis, you can see at the very distal end is the resting zone. Adjacent to the resting zone is the proliferative zone, and the zone in pink is the zone of hypertrophy, Here the cells become very large. They contain a lot of glycogen, and they are about to be infiltrated by blood vessels, and this becomes the zone of provisional calcification, which forms the woven bone. إذا بتطلعوا على الperiphery, هيدي normal. They are usually normal. I will be showing you these. In the physis, the columns are short and separated by wide fibrotic septa with decreased numbers of chondrocytes and disorders in endochondral ossification with abnormal cartilage matrix. This is the look of a child who has had dystrophic dwarfism. You see that there is kyphosis of the mid-cervical spine. This is associated with spinal stenosis, and they can have all the signs and symptoms of any compression of the cord or nerve roots. So keep this in mind. They will have a cervical spinal myelopathy. The spinal stenosis is variable in occurrence, and finally, they may have an associated cleft palate, which occurs in 58%. It varies in severity from mild to severe deformities, where the child is unable to walk. This is the cleft palate of a child who has dystrophic dwarfism. The ossification centers, when apparent, besides being late to appear, especially the capital epiphysis of the femur, they appear flattened and subluxed. And this is how we receive these patients. It's a complete disaster, and many times we kind of wonder, what can we do for this child, I repeat, child, not an adult, with such findings? Yani, they are usually either children or adolescents. And what would you do? That's the question. This is another patient who has coxa vara, and a planning was made to do a valgus osteotomy on the patient. Mind you, we cannot do a Salter. We cannot do a Pemberton. Why? Because they have such an irregularity in the head that the result won't be good. The only thing we can do is either do a shelf procedure or do a valgus osteotomy. So coxa vara is common in these patients. They have flexion contractions of the hips, knees, and elbows. The radial head may even be dislocated. The problem with the club feet, many of these you cannot work on the soft tissues. You cannot work on the tendons. Many of these you might have to work directly on bone. And there have been 2 cases that I ended up doing a talectomy on the patient and correcting the deformity. It's quite difficult. These patients end up walking, of course, not normal, but at least they can be on their legs. This is a clubfoot deformity, and the toe, like the thumb, is perpendicular to the rest of the foot. The metacarpals and metatarsals are both short. They are short. طلعوا على الصورة تحت. They are rectangular, and thus one would see the typical hitchhiker's thumb And the explanation why does it occur إذا بتطلعوا بالفيرست metacarpal مش موجودة لحتى أو قصيرة كتير. So there's no support. So for this reason, they become perpendicular to the rest of the metacarpals. And this is typically a hitchhiker's thumb, and it adds to the description done by the Greeks, calling it a crooked child, which is diastrophic, and in Greek it means crooked. These are larger views of the foot and the cauliflower ear. Another view to show you it, never to forget it. Look at the nasal bridge, it's depressed. The skull does not appear large, but the problem with they have many cervical spine anomalies. There was one of my cases that was born without an odontoid process. And these children have considerable instability, and they all end up with an occipital cervical fusion. So they are difficult to manage, and there is no place in my mind for conservative management. All need surgical intervention. You have to release whatever soft tissues that you think is important. And finally, following correction, you should put a brace. Why? Because recurrence is high. This is a patient who has dislocated hips with thoracolumbar scoliosis. And these, believe me, are very resistant to treatment. This is showing the knee of how you have a dislocated knee, and in the other view, you have a dislocated elbow. They are born without that. And if you look at the arrow behind, it's pointed to a case where the odontoid is absent. So these are the club feet that you can be faced with. These are the further club feet. This is now, if you have a dislocation of the patella, you have to release the iliotibial band very early. Otherwise, the treatment becomes very much more difficult later on. When cervical kyphosis exists with evidence of progressive cord compression, one should resort to early decompression with a combined anterior and posterior fusion. Now I discussed diastrophic dwarfism. I want to ask Khalid, Dr. Khalid. Dr. Khalid, you find this interesting?
Yeah, very interesting.
You find it interesting?
Yeah.
I think they should know about these. And this, we ask in the board. I put a few questions, but not difficult questions. I might ask, describe what deformity could one have if he has cauliflower's ears, if he has a hitchhiker's thumb, if he has severe club feet. رأسا لازم يعرفوا إنه it's a diastrophic dwarfism. Now we go to the second. Achondroplasia. This is the most common cause of dwarfism. بس بدي يطلع إذا في pediatricians وإذا في orthopedic residents يطلعوا بيقدروا يقولوا كتير من هالصورة تقشعوا بالنose and the nasal depression. بالmandible, it seems as if it's a bit protruded. The skull is large. These children have hydrocephalus. لننزل لتحت تطلعوا بالarm. The arms are short compared to the forearms. ويا ريت عندي الصورة من تحت يكون عندهم pot belly وumbilical hernias. So, achondroplasia is the most common short-limbed skeletal dysplasia. It is caused by gain of function mutations in the FGFR3 gene. The FGFR3 gene is a common question that we ask in the exam. Why do we ask this question? Because achondroplasia, dysplasia or achondroplasia is the most common cause of dwarfism. You have to know what is the defect. You should say that it's a defect in the FGFR3 gene, which cause generalized impairment of endochondral bone formation, but not of the membranous. يعني بتقشعوا العظم قصير بس عريض. ليش؟ لأن العظم is being formed subperiosteally by membranous bone formation. Endochondral bone formation اللي بتخلي العظم تطول بالطول is disturbed. There's not enough growth, and I'll show you this on bone. All achondroplastic individuals have the same mutation. تقشعهم بيشبهوا بعض. تمشي على الطريق تقشع اثنين تقول هؤلاء اخوه. And the clinical manifestations are quite homogeneous among patients. The clinical features include short stature with short arms, which is known as rhizomelic. تعرفوا انه when the arms are short, it's called rhizomelic. When the forearm is short, it's called mesomelic. And if the hand is defective and short, we call it amelic. So you have to think of these points. Disproportionately, they have a large skull with prominent forehead and mid-face recession with relative prognasticism. يعني prognasticism, the mandible is protruded. بتلاقي the angle of the mandible is obtuse, not acute, and it's protruding. They have thoracolumbokyphosis with prominent lumbosacral lordosis. The lordosis occurs in response to the kyphosis that occurs at the thoracolumbar region. They have rapidly progressive stenosis of the foramen magnum. I will show you a case after birth that may lead to hydrocephalus, apnea, quadriplegia, and even sudden death in infancy and early childhood. Achondroplasia, they have a marked dwarfing of the body height. They are far less than the lower 30th percentile of growth in height of the individual. The epiphysis is normal, but is indented in the metaphysis. انتبهوا على كلمتي. The epiphysis is normal, but is indented in the metaphysis. And we call this the ball and socket. Why does this occur? Because the endochondral bone formation is not normal. The membranous is normal. The membranous is growing, بتعمل غطا لها, and it becomes like a ball and socket. The lower ends of bone become flared. They enlarge like a bell. And there is a normal apparent diaphysis, but also is flared secondary to the disturbance and growth. Now, نطلع بهالصورة. تطلعوا بالدistal femur. تقشعوا, it is enlarged distally like a bell. like an early Mayer flask deformity, early Mayer flask appearance. Why is it? Bone is being formed at the periphery. Poor bone occurs here. بيصير فيها defect. So this covers the area, and the ossification center becomes within this defect, and we call it a ball and socket deformity. The ball is the ossification center. The defect is due to lack of growth of the physis, and the widening is secondary to membranous bone formation. شغلة تاني طلعوا بالفيبولا هون، فيبولا طويلة. It's growing more than the tibia. So the problem affects the tibia more than the fibula. This is how the patient looks. لأن الأرم قصيرة، الفورارم طولها طبيعي، والإيد تقريبا طبيعي. بس قصيرة. لوين بتوصل؟ بتوصل على الجريتر تروكانتا or iliac crest. ما بتوصل لتحت like a normal individual. They have deformities due to disturbances in growth around the knee, and they have thoracolumbar kyphosis with lordosis. هلا بتقشعوا everything is disproportional. طلعوا هون واصلة بس على الإلياك crest. The thorax is of normal height. So this is a disproportionate dwarf. Achondroplasia is a disproportionate dwarf. So please compare this. شغلة تانية I would like to mention, which is also very important, is that they can have a pot belly. يعني بيكون عندهم umbilical hernias, which are more common than others. وشغلة تانية طلعوا بهيدي الصورة بتقشعوا ما قادر يجلس الكوع. He has a flexion contracture of the elbow. Why? Because some of them not only have flexion contractures, they can have subluxation of the head of the radius. So please pay attention. So from top to bottom, pay attention. The protruded chin, depressed nasal bridge, large skull if they have occipital cervical stenosis. They have the shorter arms. Keep these in mind. So it's the most common short-limb dwarfism. It occurs in 1 in 40,000 glide births. خليني لكم أنا بشارد إنه كلكم ما عم تطلعوا بهاللكشر. عم بيقولوا 1 من 40,000. إيش شو بدنا فيهم هول؟ ليش نوجع راسنا فيها؟ لا. في ناس في orthopedic surgeons بيلاقوا بيستفيدوا أكثر إنه يعرفوا عنهم من ما يعرفوا. لأن if you know about them, one case will tell the other, and you'll have many patients coming to you with these problems, and you can build up your clinic partially on these. So you have to know, look, I know about these. I have many patients, many referrals, when they give up not knowing what the patient has, and they send them to me. I make money out of them if you love money. I'll tell you this, it's very important. So it's nice to know that it's in the few that are not mutations, that they are autosomal dominant. But 80 to 90% are the result of spontaneous mutation. So if the parents come to you and say, is there a chance of another child? You have to say, answer to God, because there's no proof that this will occur. Because we know that this is a mutation due to something we don't know of. So you tend to tell the family that they have the same risk of having a similar child like anyone else in the population. But we know that if the male is old, and the wife is young, we know that is a higher incidence. So you can tell them, divorce your wife and get an older woman. Or you tell the woman, divorce your husband and get a younger man. Now, many times my residents come and show me this photo. They tell me, how can we tell the difference between this photo of a patient with achondroplasia from a patient who has osteogenesis imperfecta? It's very simple. Look at the skull. If the skull is enlarged and you have hydrocephalus, this does not occur in osteogenesis imperfecta. In addition, they are not rhizomelic. And in addition, in osteogenesis imperfecta, you have multiple fractures. And this does not occur in achondroplasia. So we have a large head, we have frontal bossing, we have a protruding jaw, we have upward turned nostrils. These children also have otitis media, and they're taken to ENT specialists to treat them. And we spoke about hydrocephalus and lumbar lordosis. We know that they have shortness of the lower limb, which we call rhizomelic. The root portions of the limbs are shorter than the middle and distal portions. It's associated with soft tissues of the limbs. They appear excessive, of course, because of shortness. They appear flabby. And the average height of a male is 130 centimeters, while for a female, it's 124 centimeters. Another important point that we haven't spoken yet about achondroplasia is that they have trident hands. Trident hands. What we mean by trident hands is, you see this, between the third and fourth finger, there is a gap. And as you try and bring them together, they won't come together because there is a block in the metacarpals between the third and fourth fingers. And you see it like this. And this is pathognomonic nearly. Other conditions do have it, but this is more common in achondroplasia. This is a profile of a patient who has achondroplasia. The lower chest, it's flat and broad. The abdomen is protuberant, and the buttocks are prominent, secondary to the lumbar lordosis. This is a child position showing the trident hands. This is a child that was newborn with x-rays. You see that they have short ribs and they are like canoes. And they have tough bone compared with osteogenesis imperfecta, and they lack funnelization. يعني إذا بتطلع a child with achondroplasia, the bone is tough. They have flexion contractions. حكينا عن الhips, kyphosis, thoracolumbar. We're repeating things over and over, but we know that the interpedicular distance. We know that بالvertebra you have the lamina and you have the pedicles. It is the pedicles that insert on the body. The distance between the pedicles becomes less as you go down from lumbar 1 to lumbar 5. And with age, this increases, and they will end up having lower lumbar spinal stenosis. And I have operated on quite a few and did a decompression laminectomy from L1 to L5. This shows you what I'm trying to tell you. First of all, on the lateral view, you have thoracolumbar kyphosis, and this is compensated by the lumbar lordosis. And on the right-hand side, you see that the pedicles in العيون الديك, you see العين هون. هالعين البedicle وهالعين. The distance between here and here, instead of increasing as you go down, it decreases. عم تنقص عم تنقص عم تنقص وعم تنقص. يعني عم تحرس it's compressing the cord as you go down. So don't forget, this is the kyphosis, this is the lordosis, and they have a flat chest. This is the kyphosis shown over here. The hips are flat, they are horizontal. You see it? You see the femurs are short, but thick. Okay? Thick. And this happens in every bone, a long bone where you have growth by endochondral and membranous bone formation. The endochondral is blocked, the membranous is continue forming bone. Now look at the pelvis in these. The pelvis, many times we put a pelvic view. You see that the iliac bones are like the wings of an eagle out. If you look at the pelvis from inside, the Americans call it the champagne deformity. Champagne deformity. If you look at the ischium, you see that the ischium, secondary even to the contraction, the ischium is wider than normal. And you see the deformed acetabulum, which is horizontal. Another problem what we have is that you can have pressure on the sciatic nerve secondary to a narrow sciatic foramen. So don't forget these. This X-ray, I call it a very important X-ray. Now, let us come to this. The tips of the fingers don't reach below the greater trochanter. طلع البروفايل. طلع وين إيديه واصلين. Okay? And one may note the dramatic shortening of the long bones of the ribs. That's why many of them have difficulty in breathing. The chest is smaller and narrower than normal individuals. طلع هون. You see it's narrower. بعدين they have a pot belly. بعدين look at the depressed nasal bridge. Then look at the skull. It looks large. This child has hydrocephalus. So the chest is flat and flared distally. من شان هيك أوقات بنسميهم جرس. The acetabulum is flat and broad. The humerus is short with limitation of elbow extension, يلي ستقيلكن إياه عدة مرات, and supination of the forearm. They have overgrowth of the fibula, and they have a lot of ligamentous laxity. طلعوا على الفibula. The fibula is longer. This doesn't look like a very severe deformity over here. Shortage of the chondroblast with failure of columnization is the problem. It is in the zone of hypertrophy, where cartilage cells begin to accumulate glycogen. They become enlarged, and they get ready for degeneration and invasion by the zone of provisional calcification. Adequate bars of calcified cartilage fail to occur. Ossification is sparse, and irregular periosteal ossification is normal. طلعوا هلا شو عم بحكي. Hone, this is the resting zone. This is where the cells begin to take all the nutrition and it begins to form. It becomes the proliferative zone. And this is the hypertrophic zone, which is mature cells. And then these are the zone, the vessels invade the area. They begin to destroy the area and they form the zone of provisional calcification, which gives you the primary and the secondary spongiosa. This is tissue obtained from a patient. This is with bone horizontal, and this is with it vertical. You see the bone, the periosteal bone formation is normal. But over here, it's lousy, it's weak. So, هون عندك periosteal bone, هون عندك, it forms a cup. And over here becomes, the epiphysis becomes the round structure lying within the cup, and we call it the ball and socket appearance. Now, look at this, shows it further. And look at the fibula وين واصلة لتحت. And this is another patient, never forget. It shows you حطيتها الصورة لأن تقشعوا الإيد لوين واصلة للإلياك crest. When this child has hydrocephalus, this is the profile. This is the child looking at you with the protruding mandible. This is a lateral view. Look at the depressed nasal bridge. Don't forget these. Please don't forget these. You have to know. This is بتجي الام خايفة جاي لعندكم يا pediatricians. ليكو ابني في عنده protrusion بظهره, meaning that he has kyphosis. Many of these don't need surgery and they grow out of it with age. But those that don't grow out and they increase, then you should do surgery. Okay? This is showing the champagne glass appearance. It shows you the bone of how well it's formed width-wise, but length-wise, it's not well formed. These are the hands. They have shortening of all the bones. They have squaring of the bones, of metacarpals, and the phalanges. So these are what I said. Decompression if you have stenosis, osteotomies if you have coxavara. You might need to do a shelf operation. The tissues are elastic, the vessels are tortuous, and they tolerate lengthening. One of the major surgeries we're doing nowadays is we're lengthening the thighs, we're lengthening the legs, and we lengthen them using the Elizarov, and we lengthen it at 1 millimeter per day, not more. In the spine, you see the spinal stenosis, narrowing. Look at the pedicles, how short they are. They are short. Over here, they're rather better, longer than the ones below. This is an axial cut. This is a normal patient. The pedicles are normal. Over here, this is a patient who has achondroplasia and stenosis. The pedicles are short. There is a narrowing canal, which would result in spinal cord stenosis and pressure and all the signs and symptoms. This is a patient who had achondroplasia. She was stubborn. She wanted to become sexy, and she was operated and had lengthened. Rods were put through the femur and tibia, and she was lengthened. Look at how well she looks now with length. Now, let me tell you, one of these problems these children have is on walking on the roads. When they're going up the sidewalks, many don't take them into consideration. And if they want to go up a sidewalk, they have to sit, then get up on their legs to get up. In the States, they have taken this as a precaution. If you go to the bathrooms, in the States, you see that there are bathrooms for achondroplastic dwarfs and bathrooms for the regular. So, enough. Are there any questions on achondroplasia? Any questions?
Dr. John, the names with you can ask some of them.
اوكي لا بسألهم. اوكي. في سامي صالح محمد بحرين.
سليم بحرين. تعال
سليم. I want you to list all what I said, a list of the deformities that a patient with achondroplasia can have. شو؟
أهلا دكتور.
أهلا فيك.
أهلا دكتوري.
شو الديفورميتيز اللي بتخلينا نقول هيدا المريض عنده achondroplasia؟
دبرس النازل بريد.
Yes.
There is depression in nasal bridge. Protruding المنزل also.
برافو. Very good.
short structure وتريدنت hand وريزوميلك dwarfism also. Also thoracolumbar kyphosis and excessive lordosis and short arm.
Why do they have a cervical myelopathy?
Due to stenosis.
Stenosis where?
cervical.
برافو عليك. برافو. طيب خليني اسال احمد بعمران. ايه احمد هلا سمعت he's on duty. طيب
duty today احمد. another one.
طيب شو اسمه؟ ماجد الحيتاري.
ماجد
كيفك يا ماجد؟
دكتور another one please. Majid also in another hospital he's in duty today.
طيب وليد الحشيدي. يلا يا وليد.
لا يلا معك
وليد عندك ولد عنده dystrophic dwarfism، عندك ولد عنده achondroplasia، عم تطلع بالايدين، كيف فيك تقول انه هيدا اكثريه عنده dystrophic dwarfism او achondroplasia؟ شو في بالايد يلي بتقلك عنده هيك او هيك؟
In achondroplasia, there is brachymetatarsia or
بالايد تبع الدايستروفيك دwarfism شو بيبين فيها؟
hitchhiker thumb, abductive thumb.
Hitchhiker's thumb. A thumb which is perpendicular to the rest of the metacarpals.
Also,
this is something you should never forget. Okay?
Okay.
طيب يلا خلينا نكمل بالتاني وحدة. هلا بدنا نكمل. هلا pseudo achondroplasia. These are types of achondroplasia that affect certain parts of the body more. إذا بتطلعوا بوجه المرأة بتطلعوا بتلاقيها تقريبا نورمال، بس بتطلعوا بجسمها بتلاقي عندها كل الفايندينجز تبع الachondroplasia. بتلاقي عندها deformities، عندها dislocations، عندها kyphosis، عندها proximal femur defects. The hips are not normal. And so this condition involves the epiphysis and the metaphysis. This is what makes it different than achondroplasia. The epiphysis is not normal. مشان هيك if we go back up, تقشعوا the head of the humerus is not very normal. تقشعوا elbow is not very normal. تقشعوا tibia is not very normal. وبتطلعوا distal femur, both membranous and endochondral bone is abnormal. Don't forget this. But they have the same findings. They have kyphosis, they are rhizomelic, but the difference between it and achondroplasia is that the pseudo involves both endochondral and membranous bone formation, while achondroplasia involves only the endochondral bone formation. Keep this in mind, okay? So that's all I want you to know about this condition. These are how these patients look. They have multiple deformities. They are typical dwarfs. The elbows are in flexion. They reach the iliac crest, not longer. And both sides of the joint are involved. Okay, don't forget these. I'm going quickly through these because I have a lot to discuss. Okay? They have very common findings in both. They can have absence of the odontoid process. They can have problems in the cervical spine. The chest is not as narrow as the chest in achondroplasia. They both are rhizomelic. They both can have coxavara. So keep this in mind. They have ligamentous laxity. Now, if you look at the hips of these patients, whether it is any form of achondroplasia or multiple epiphyseal dysplasia, many would come to me and say, isn't this leg calvipersis disease? No, because you don't see the subchondral translucency and you don't see the normal stages which occur in leg calvipersis disease. These patients, you need to do a valgus osteotomy. We don't like to do a Salter on these patients. Why? Because the acetabulum, there is an incongruency between the head and the acetabulum. We can be creating a problem in these patients if we do that. In the older patients, we can do a total hip on them. Now we come to metatropic dysplasia. And I'm going to go very quickly through these very uncommon. They all are rhizomelic. طلع على proximal hips. They have short limbs, relatively long trunk. Later on, have a progressive kyphoscoliosis, lumbar lordosis, and may become severe. These patients are autosomal recessive and prevalence of 2 per million. And it was first described by Marato et al. Now, let me tell you, and I have asked Dr. Khalid to record all my lectures. What I would do and insist that Dr. Khalid gives you a copy of this lecture so that you can review it. Because whatever you retain is a gain to you. We do ask questions, but we don't ask many questions on this subject. We ask only the essential questions. This is a patient with metatropic dysplasia with severe kyphoscoliosis. We have the same findings, actually. They have restricted chest mobility. The head and intelligence is normal. At birth, a unique feature is a triangular fold on the skin involving the tip of the coccyx. يعني أنا بدي أقول لك, if you're a resident in a prominent hospital and the child is born with a tuft of skin just over the anus, dangling down, but some more than up, you should not take this lightly. You should investigate the child. You should investigate the child for any anomaly, because many of these can have a form of achondroplasia, a form of disturbance in growth. If you look at the X-ray on the right-hand side, you see that these children are rhizomelic. You see that there is funnelization. You see all the findings that you get with an achondroplastic dwarf. So if you miss this and you don't tell this to the family at 1 year, 2 years, 3 years will begin to curse you. And once in a while, you'll have chest pain because you'll feel that somebody is cursing you because you didn't warn them that this could happen. Well, if you tell them that this possibly could happen, possibly, and stress possibly, because if it doesn't happen, they will be against you. But if it happens, they'll be for you. So if you tell them, you say possibly happen, you should be checked, and you can escape with a good impression. If you look, they have this extra portion of the coccyx, and they call it the tailbone, and skin overlaps it. And these patients, you have to search for them having any dwarfism. This is showing you the area of the coccyx. They walk with a waddling gait. Why? Because they have a varus deformity of the hip, and they have flexion contraction deformities, and both knees can be dislocated like any achondroplastic dwarf, and the feet could be in valgus. They develop severe thoracolumbar scoliosis with the camel hump and lumbar lordosis, which occurs with achondroplasia, but the scoliosis is not severe in achondroplasia, but in metatropic dysplasia, it can be high. Okay, so keep this in mind. These are the hips on these patients. The ribs are short, flared, just like any other form. This is, they have platyspondyle. What we mean by platyspondyle is that the vertebral bodies are short, they are flat, they are narrow, but they are long in the anterior posterior direction. They don't have narrowing of the interpedicular distance. They don't have spinal stenosis. The differential diagnosis you have to include is mucopolysaccharidosis, which is absent urinary mucopolysaccharides being not present in these cases. Spondyloepiphyseal dysplasia, achondroplasia, and there's a Niest disease. I have to go quickly, fellows, because it's going to take us too long. Okay, so this is what you should know. They can have problems at the occipital cervical region. Nias disease. I'm going to go very quickly. You see, if you look at the hands, the metacarpophalangeal joints are completely abnormal. And over here, we will be coming across them. Look at the hips. In Nias, they have hip problems, and they have coxavara, and they hardly have an acetabulum. It's present with a disproportionate dwarfism. They have kyphoscoliosis. They have hypertelorism. They have flat facies, a depressed nasal bridge. They have prominent eyes, myopia, detached retina, cleft palate, hearing loss, and limited joint movement. This is a patient who has Nias syndrome. You see the eyes, they don't see well. You see they have excessive amount of hair and then depressed nasal bridge. Let me tell you more about them. They have also cleft palates. They have stiffness and deformities of the joint with pain. Fingers are long and knobby. Intelligence is normal. This is the same X-ray I showed you before. They have a knobby joints. They present with disproportionate dwarfism. They have kyphoscoliosis. I showed you the hypertelorism. They have flat facies, depressed nasal bridge, myopia, cleft palate, etc. So you have to think about this. Okay, the epiphysis is irregular. In many of these patients, they have an absent odontoid process. The thorax is normal, wide or bell-shaped, and the ribs are long and wide anteriorly. They have large chondrocytes in a loose matrix, empty spaces, and if you do an analysis, you see that there is an excess amount of keratosulfate in the urine. There is an abnormality in the cartilage proteoglycan metabolism. This is what you should know about the Nias. Anatrophic dwarfism, I'm not going to go much, but these are severe forms of achondroplasia. Many of these are stillbirths. This is an example of such a patient. It means death-bearing and is severe variant of achondroplasia. And it's caused by a different form of FGFR3 mutations that give rise to more severe biological consequences than seen in achondroplasia. They have a large head. They have shortening of the limbs. Look at them. The picture, it will tell you. They have a flattened vertebral bodies. They have short ribs, a narrow pelvis, bowing of the long bones and flaring of the metaphysis. And most of them die in infancy due to respiratory insufficiency. إذا بتطلعوا بالصورة من تحت, you see what a narrow chest they have. And these are the short, stubby bones. This is a stillbirth. You can see of how the child is born. Look at the chest, the narrowing of the chest, the pot belly, the small pelvis. Achondrogenesis is again another form. I'll tell you something. If you take thanotropic dysplasia, which is achondrodysplasia of a more severe form, you have to keep this in mind, or the agenetic form of chondrodysplasia, you see that it's more severe And you see in these cases stillbirth. And you really don't need to have any knowledge about that. Hypochondral dysplasias, it's in other form. They are all different forms with nearly the same presentations, but some are more acute than others. These patients do have a trident hand. You see between the third and fourth finger, and you see over here, even if they want to bring them together, there's so much soft tissue over here that prevents it to come closer. So this we call them achondroplasia tarda, and they are described by different individuals. This is a patient, how he looks. He is short. He's usually not more than 130 to 135 centimeters in length, but they look better than other achondroplasias. Okay, so keep this in mind. Now, hypochondroplasia are similar conditions. We come to a form which I like very much. Many times I get patients referred to me with such an X-ray. They tell me, does this patient have osteomyelitis? Does he have a tumor? Does he have heterotopic ossification? That's the question I keep on getting. Malrheostosis is a condition characterized by distinctive cortical hyperostosis. We compare it to wax. When it's being heated, it melts. And melos in Greek means limp, rein to flow, ostos is bone. So you have melos, malrheostosis, malrheostosis, which stands for each part. You have a limb, you have flow, and you have wax, and you have bone. The hyperostotic process causes pain. Why? Because this bone, when it declines, there are small nerve fibers that are being blocked or undergo pressure. They will have pain in the limbs. The limb length discrepancy, the joint contraction, muscular atrophy, and erythematous skin changes add to the pain. The dripping candle wax-like cortical hyperostosis may affect a single bone, but more commonly it involves multiple continuous bones. If you look at these bones, and there is a condition which these bones form and involve the medullary cavity, and this is known as osteopetrosis. We have the major form and you have the minor form. The minor form, they're born with no marrow cavity, and they die at early age. The major, they live into adult life. This is another patient who has osteopetrosis. Dysostosis multiplex. I like to show you pictures. I'm going to show you dysostosis multiplex belongs to the group of mucopolysaccharidosis. Look at this child. This child has morcules. You see the depressed nasal bridge? Look at the interocular distance, which is larger. Look at the skull, look at the chin, look at the teeth. Everything tells you the character of this condition. It belongs to a group of metabolic diseases that involve more than one tissue system. And these include the skeletal, fibroblastic derivatives, the reticuloendothelial cells, the nerve tissue, the epithelial tissues. They have excessive and abnormal quantities of mucopolysaccharides. These are produced by abnormal fibroblasts, and these are stored in cells of various systems and are excreted in excessive quantities in the urine. The end result would be a disturbed growth, a disturbed reticuloendothelial function, a disturbed function of the brain. There are several types, but here only Morquio and Hurley's disease will be discussed. This is a patient with Morquio's disease. This, as a matter of fact, I took the slide from the internet. They have a flat nasal bridge. They have thick lips. These children have a disturbance in hearing. They have a hearing loss. They have dysplasia or abnormal bone size. Developmental delays and mental retardation exists. The organs are enlarged, the heart, the liver, and spleen. And they have heart diseases and respiratory issues. And these patients die in middle ages. These are the deformities that one can have. This is a patient, two patients with Morquio's. They are lovey-dovey. Look at their teeth. Look at the nasal bridge, which is flat. Look at the eyes. The eyes are wide apart. The hands, they have deformities in the hands. And they can have a deformity which is very similar to Madelung's deformity. And this is the shape of a patient with Morquio's. They have a pot belly, they have pectus excavatum, they have flexion contractions of the elbow, deformities of knee, either varus or valgus. And this is a series of patients who have it, and the patient on a wheelchair. Look at the forearm. Now this is, if you want, you can call it a mesomelic defect. Why? Because it affects the forearm and not the arm and not the hand so commonly. If you look at the physis, it's not well formed on the ulnar aspect. As a result, the whole wrist drops towards the ulna. They also can have kyphosis, and this condition is transmitted as an autosomal recessive and occurs in multiple siblings. Multiple siblings. They have kyphosis and they have lordosis with severe disability. These children are known to have excessive hypotonia and joint laxity, and with time they end with marked joint deformities. This is a patient who has Morquio's. Look at the profile, look at the pot belly, look at the flexion contraction of the hips. They have a knobby appearance of the epiphysis of the elbow, knee, associated with ligament laxity and muscle hypotonia. This shows you the relationship of the wrist and the distal radius. They have also coxavara with absence of the acetabulum. They are very difficult to treat. This is a patient who has bilateral coxavara. You can see it over here like a mulberry appearance. And this patient underwent valgus osteotomies. This is another patient with deformities of knee, flexion contractures. They can have corneal clouding. They have hypoplasia of the odontoid. Keep these points in mind. And this is the patient following a valgus osteotomy done 3 years ago. And you can see the result isn't bad. If you compare between the hand of an achondroplastic dwarf on the left side and the smaller and that of the Morcus right, and you can see the difference. There is an extra amount of paratin sulfate. You have to know this. The abnormality affects chondroblastic and osteoblastic maturation function and proliferation. They have Riley bodies in the reticuloendothelial cells. So you have to keep this in mind. These are the deformities that you can have. And these are a patient with cretinism, a patient with achondroplasia, and in the middle, gargoylism. Usually these children become known to have this condition by the time they are 6 to 18 months of age, and males to females are 1-to-1. They have a short neck, they have dorsolumbokyphosis and widened joints. If you look at the X-ray, you see that they have vertebra planum, flat vertebra, and they have a small sacrum, broad ribs, irregular and broad ends of bone. They have flaring of the iliac bones, short tubular bones of the hands and feet, knock-knee deformity. This is how a sketch of a vertebral body would look. This is the platyspondyle, which are flat vertebral bodies. And there is an increase in the anterior posterior distance of the vertebral body. Then you have a wine glass appearance of the pelvis. In a normal individual, you have a brandy snifter. Hairless disease, I will say it's a more severe form. They have clouding of the cornea, and these are the findings in brief. They have frontal bossing, hypertelorism, gap teeth, short neck, corneal clouding, nasal bridges flat. They have an intellectual disability and hepatosplenomegaly. Now we're finishing from these cases, and we're going to move in a more interesting aspect, which is, I will show you now. I hope I get over it. Well, we don't need this. Spondyloepiphyseal dysplasia. These are the same findings, and we're going to be moving very soon into actually, you have to have this lecture by your side to know and describe. And you can see in spondyloepiphyseal dysplasia, you see they have kyphosis, but the vertebra are blunted anteriorly. I just want to arrive at somewhere else because we won't finish tonight if I want to discuss these all in detail. I will be coming to essential ones. This one is more important for me than others because this is confused with Legg-Calvé-Percy's disease. Can we take 5 minutes break, Khalid? Khalid,
Yes, sure.
5 minutes break.
Okay. Take your time.
Look, Anna, I want to ask, are they bored?
No, they are they like the picture. They are interesting in it.
They should take this lecture, study them
Yes.
individually.
Already
They should know
we
about
recorded.
them. Believe me.
Yeah.
At,
We
at
recorded
John
and I will
Hopkins,
give-
at John Hopkins University, if the resident, while undergoing examination, they ask him a question on this and they don't know, they have to repeat the year. Bill Canadian Fellowship, they have to know about it. I'll tell you, this is very essential for their clinical practice because they will get cases, and this way it will attract more patients from the sides of the parents if they know what the problem is.
Yeah.
Yeah, I've taken 2 minutes breaks, 3 minutes.
Okay.
This part of the lecture is going to be more interesting. Yalla. We're going to speak about multiple epiphyseal dysplasia. As I said, this is very important because it tells us between a dysplasia and avascular necrosis, Legg-Percy's disease. There is a differential point between the two. Multiple epiphyseal dysplasia is a congenital disorder caused most commonly by an autosomal mutation in cartilage oligomeric matrix protein on chromosome 19. Patients present with a form of dwarfism characterized by irregular, delayed ossification at multiple epiphyses. The diagnosis is made radiographically with presence of irregular, delayed ossification at multiple epiphyses. Multiple epiphyseal dysplasia is a group of disorders of cartilage and bone development, and primarily it affects the ends of long bones in the arms and legs, the epiphyses. There are two types of multiple epiphyseal dysplasia, which are distinguished by their patterns of inheritance. It can be autosomal dominant or autosomal recessive. The recessive multiple epiphyseal dysplasia may also cause malformations of the hands, feet, and knees, and have scoliosis or other abnormalities. These are the deformities. You can see it can affect the elbows, can affect the wrist, the hands, and most people are diagnosed during childhood if they have the recessive form. But mild cases may not be diagnosed till adulthood. The dominant form is caused by genetic changes in the genes that I'm not going to mention about them, and the recessive likewise in the gene mentioned in this slide. You can see the changes that can occur. You see the epiphysis becomes irregular, disturbance, it's no longer smooth. The hips, you have high incidence of degenerative arthritis and flattening of the epiphyseal ossification center. The hands are very much different, and you can see that the joints can be involved, especially the distal metatarsal phalangeal, the distal metatarsal phalangeal joint, or the metatarsal phalangeal joints. Multiple epiphyseal dysplasia describes a spectrum of autosomal dominant disorders, and these are characterized by epiphyseal dysplastic changes, resulting in mild to moderate short stature. They have genovalgum and early onset of osteoarthritis. They are short. They have hyperextensible fingers. These are present in patients with severe involvement. So they have short, hyperextensible fingers. The diagnosis is usually made in mid-childhood with reports of pain and joint stiffness in patients with short stature. Radiographs demonstrate delayed epiphyseal ossification with subsequent irregular development of the epiphysis. The spine is usually not affected. The clinical phenotypes are variable, ranging from mild epiphyseal abnormalities in the hips that can lead to a misdiagnosis of bilateral leg calcificaris disease to severe widespread epiphyseal dysplasia with joint contractures, osteoarthritis, and short stature. The hips of children with multiple epiphyseal dysplasia, the capital femoral ossification is delayed, with subsequent fragmented ossification, and it eventually coalesces to form an intact but small ossific nucleus. You see that the epiphyseal ossification center is flat. This does not occur in leg calcificaris disease. You know that there is coxa-vara here, and these patients would benefit from a valgus osteotomy. Although the radiographic appearance in the fragmented stage appears similar to that seen in patients with leg calcificaris disease, the typical stages of sclerosis, collapse, fragmentation, and reossification are not apparent. Radiographic appearance of the hips is shown over here of a patient with multiple epiphyseal dysplasia. Osteonecrosis can occur in the hips of a patient with multiple epiphyseal dysplasia, thereby complicating the radiographic appearance. Management in this circumstance is similar to the containment methods used for patients with leg calcificaris disease. Treatment is usually physical therapy and pain management, Surgical osteotomies, arthroplasty are indicated in patients with progressive deformity or degenerative joint disease. Painful stiff joints are managed by avoidance of activities that result in significant joint stress, administration of non-steroidal anti-inflammatory drugs, and aquatic and physical therapy. These separate genetic loci have been, three separate genetic loci have been linked to multiple epiphyseal dysplasia. Mutations causing all clinical forms of multiple epiphyseal dysplasia have been identified in the gene encoding comp. The phenotype of mild pseudoachondroplasia patients overlap with those of multiple epiphyseal dysplasia. It is a structural component of hyaline cartilage, intervertebral discs, and the vitreous body of the eye. Type 9 collagen decorates the surface of type 2 collagen molecules to which it is covalently cross-linked. So, it all depends on the presence of type 2 collagen within the joint. And the enzyme, the genes in which they form is called 9A2. So these are only gene studies and not in the field that we have to know. Ellis Van Greffel, just to mention, these are deformities which they have polydactyly, and these patients, it's a rare genetic disorder. It's characterized by short limb dwarfism. They have polydactyly, and they have abnormal development of fingernails, and over half have congenital heart disease. These are the patients, they have extra fingers, and they have congenital heart disease. The teeth are usually not normal. They have very weak and thin hair, and this shows you the multiple deformities that we have in this condition. Okay, so I don't want to. Then you have dyschondrosis. These are rare conditions where they have mild short stature, they have mesomelic, as you mentioned, the forearm problems, and they have shortening, and they are present with Madelung's deformity. This is a patient that has dyschondrosis and has Madelung's deformity, where they have a deficiency in growth of the physis, especially on the ulnar aspect of the distal radius. This is how it looks and how they present. Okay, the radiographic features are typical of Madelung's deformity with bowing of the radius and dorsal dislocation of the ulna. Mutations in the short stature homeobox shocks gene have recently been implicated as the cause of dyschondrosis. I don't even know how to pronounce it. Dyschondrosis. Okay, but you have to know them. This is a common, I have seen in my lifetime around 5 cases where they had cleidocranial dysostosis, which is a condition where they have absence of the clavicle and they are able to put their shoulders in various positions. The fontanelles or the suture lines are delayed in closing, and they have a disturbance in the teeth growth. This is showing you the clinical presentation of a baby girl. It is inherited by means of an autosomal dominant disorder. They have a broad forehead. They have delayed closure of the anterior fontanelle. They have increased ability to oppose the shoulders, as is shown in the diagram. They have shortening of the middle phalanges, and they have disturbances in teeth growth. The diagnosis can be made at birth, but is often delayed. Radiographic features include multiple Wormian bones in the skull and delayed closure of the sutures and anterior fontanelle. The clavicles are small and absent, and there is widening of the symphysis pubis. The disorder is caused by a mutation of core binding factor, A1, and you can see that it is important in the induction of osteoblast differentiation. The clinical features result in abnormal development of the anterior midline skeleton. They have coxavara can occur. They have a total abnormality in the development of the skeleton. The nail patella syndrome. In my lifetime, I've seen around 10 cases, and of these 10 cases, 8 cases were referred because the surgeon did not know what this patient has. They call it the nail patella syndrome because it affects the nails, mainly the thumb. There is ridging of the nails, and they call it also, another name is osteoonychodysplasia. It's an autosomal dominant disorder characterized by aplasia or hypoplasia of the patella and dysplastic nails, with thumbnails being most commonly involved. In addition, these children who come to you take an X-ray of the pelvis, and you see that there are horns of bone coming out of the iliac crest on both sides. And that's why they call it the iliac horn syndrome at times. In the past, it was known as fungus disease, and it encompasses classic clinical tetrad of changes in the nails, the knees, the elbow, and the presence of iliac horns. Nail changes are most constant features of the nail patella syndrome. If you look over here, you see the spine, there's a spondylolisthesis. You look over here, you see iliac horns. You can even get a subluxed elbow, and that's it. And the nails may be absent, hypoplastic, or dystrophic, ridged longitudinally or horizontally, pitted, discolored, separated into two halves by a longitudinal cleft or ridge of skin, and skin, or less often, thickened. The patella may be small, irregular shaped, or absent. The elbow abnormalities include limitation of extension and supination, cubitus valgus, and antecubital teresia. Iliac horns are bilateral, conical, bony processes that project posteriorly and laterally from the central part of the iliac bones of the pelvis. Look at the ridges on the first film on the left side, you see that the thumb is involved. It's usually most commonly involved. Then you have the index, you have the middle fingers, but the most common involvement is the thumb. The patella looks subluxed a bit, slightly abnormal. The elbow can be dislocated, and they have iliac horns. This is the elbow when it's dislocated, showing on the lateral view. You can see that the horns are quite large. The pelvis is open like a wing. These patients can have renal involvement, and they can also have glaucoma, an open angle glaucoma. So you have to pay attention to evaluate these patients. Up to 30% of affected individuals develop renal failure by the fourth decade of life. Glaucoma is another complication, as I mentioned, associated with this disorder. And you can see over here in the kidney, which is involved, they are resistant to steroids in nephrotic syndrome. This is an primary open angle glaucoma. The diagnosis of nail patella syndrome is established in a proband with suggestive findings and or a heterozygous pathogenic variants in LMX1B identified by molecular genetic testing. Treatment of manifestations, orthopedic problems may be helped by analgesic, physiotherapy, splinting, bracing, or surgery. MRI of the joints to identify abnormal anatomy is important prior to surgery so that appropriate surgical treatment can be planned in advance. These inhibitors to control blood pressure and possibly to show slow progression of the proteinuria, kidney transplantation as needed, standard treatment of decreased bone mineral density, hypertension, constipation, inflammatory bowel disease, glaucoma, epilepsy, and dental anomalies. This shows you the patient. Look at the right-hand side, bottom, you see the patella is dislocated, and you see changes in the joints with degeneration of cartilage. So mutations do occur leading to the nail patella syndrome. These are changes that you can see in the nail patella syndrome. Dysplasia epiphysealis hemimelica. And let me tell you something. This is called Trevor's disease. I call it because it's an easier name to give. I'll tell you, ما بيصير إلا مع some of your professors get to see this case. It's an osteochondroma that arises from the epiphyseal ossification center within the joint and begins to grow and deform the joint. At times we call it the tarsal epiphyseal A-classes, and it's described by Mouchet and Belot in 1926, and in 1950, Trevor's disease. It is very rare. It represents with an asymmetrical osteochondromatous growth arising from one side of the epiphysis involving the tarsal or carpal bones and distal end of the femur epiphysis. The medial aspect of the epiphysis is most commonly involved. This shows you one arising from the talus, another one from the medial malleolus, and an osteochondroma arising from one side of the epiphysis. And it shows you the lesion pathologic-wise. It can involve either the ankle, the knee, or the hip. They present with deformity and swelling of the joint. Early in this condition, it may be difficult to make the diagnosis because of lack of calcification of osteochondroma. Whenever one gets aware of progressive subluxation of the hip joint with progressive loss of movement, one should be suspicious of its presence. It is limited to lateral or medial half, but the medial half is more common of a single limb. Males to females ratio is 3 males to 1 female. It is commonly localized to the distal, femoral, and proximal tibial epiphysis and in the tarsal bones. Present because of the deformity or due to limitation of motion. Rarely pain is present. It affects boys more frequently. It can lead to a severe valgus varus deformity of the ankle or knee, depending on which side the epiphysis is involved. It resembles an osteochondroma with a thick zone of hyperblastic cartilage. Ossification of the tumor takes place by endochondral ossification. Areas of necrosis may be noted within the tumor. Treatment: excision of the osteochondroma with the hope of remodeling with growth. Recurrence is rare. Metachromatosis, it's transmitted autosomal trait. It affects long bones. And these patients are known to change to sarcomas. Why? Because they have a typical appearance like a multiple enchondromatosis. And this is characteristic. You can see in the fourth metacarpal, you can see the lesion over here. They present exactly like multiple enchondromatosis. The patients finally end up by having multiple deformities and shortening. Sarcomatous changes tend to occur more commonly in older patients and in the more proximal lesions. Maffucci syndrome, it occurs at an earlier age, at the age of 40. The incidence of chondrosarcomas in adults rises to 25%. Angiosarcomas and fibrosarcomas have been recorded in patients with Maffucci syndrome. The lesions appear as hematomatous cartilage reds that appear to have escaped classification ossification and migrated to the metaphysis. These consist of chondroblasts and chondrocytes. Okay. Ollius disease are multiple in chondromas. They occur more so on one side than the other. It affects one extremity more than the other. And at times it's accompanied by multiple hemangiomas and is known as Maffucci syndrome. And they can undergo metastatic, undergo metachresia or metaplasia, or change into tumor, or become sarcomatous in nature, especially with the multiple hemangiomata, known as Maffucci syndrome. They become chondrosarcomatous, and this is repeated in 35% and even higher in Maffucci syndrome. The more proximal the site of the involvement, the higher the incidence of malignant transformation. It most commonly involves the phalanges, the femur, and tibia. It has a strong tendency of unilateral involvement when bilateral is asymmetrical. They are commonly associated with unilateral genu valgum. Forearm bowing and ulnar deviation is common. Maffucci syndrome is unilateral involvement of multiple hemangiomas. Hemangiomas have been noted in other internal organs, multiple pigmented and nevi, and vitiligo are occasionally non-skeletal manifestations. They are recognized radiologically as radiolucent longitudinal streaks that involve the metaphysis and extend into the diaphysis. The overlying cortex is thinned, and calcification within the lesion is common. This shows you multiple lesions in multiple areas. Hands, feet, limbs are usually deformed. CT is of help in evaluating long bone and pelvic lesions. It clarifies cortical and parietal scalloping. This shows you a case of Ollius disease. You see its unilateral involvement mainly with soft tissue calcification, Maffucci's syndrome. Unilateral involvement mainly with soft tissues, calcification, and malformation, Maffucci's syndrome. This is another case of unilateral involvement of the tibia. It cannot be cured by curettage and bone grafting. And one should correct only angular deformities. The use of an Elizarov techniques have been of help in correcting deformities in the older child. This is a patient. You note the cartilaginous lesion in the metaphysis of both the distal femurs and tibia. Both are calcified. Pycnodysstosis, we spoke briefly about it. I will not go into it more. Okay. So they have a lot that they are known to have the parrot face, patients with pycnodysstosis. And look at the teeth, they're totally abnormal. I recently put this in because I hadn't had any photos on the patients. I was lucky to collect them recently. So that's why I included it in this lecture. This is another view taken from one of the articles. Okay. You can see that in pycnodysstosis, the distal phalanx is eroded. And I like this because this is very important when you have a patient of hyperparathyroidism where the distal tufts, the distal phalanges are eroded. And you have to put this in the differential diagnosis with hyperparathyroidism, with destruction, with patients who have tumors of the parathyroid gland, and they have in excess of hormone release and effect on calcium phosphorus metabolism. You can see that the teeth are abnormal. Apert syndrome is a condition where they have a small pointed head. You can see that the fingers are synestosed, and this is quite ugly to see. Look at the patient, he's got a special look. The eyes are protruding, okay? Likewise, like this, okay? This is acrocephalosyndactyly, very well known for syndesmosis of the phalanges, okay? And they have a wormian appearance of the skull. Look at the eyes. These are the areas that are fused. This is in an asylum where they have many cases. They put them together and they showed it. And you see that there are several syndactylies, syndesmosis, fusion of bone in the hands and legs. Piles disease is hypertelorism, flattening of the nose, huge mandible. The X-ray may be very similar to osteopetrosis, and that's why I'm showing Piles disease. When you get a complete obliteration of the medullary cavity and you make the diagnosis of osteopetrosis, then you should include Piles disease in it. Okay, so this enters the differential diagnosis of osteopetrosis. And over here, it's well known to have the Erlenmeyer flash deformity of the distal femur with valgus deformity of the knees. You have bowing of both tibias with thickening of the medial cortex in the mid-diaphyseal region. This is a patient with Piles disease and hypertelorism with flattening of the nose and a huge mandible. It's similar to osteopetrosis, very similar. And they have optic nerve atrophy may exist. This shows you it further and further. They have obliteration of the medullary cavity, and they have failure of development of the medullary cavity with thinning of the cortex with a bowed appearance. Showing you Peyer's, the early Mayer flask plus Peyer's disease. Caffey's disease, which is known as infantile cortical hyperestosis, this occurs in children up to 6 months, where you have a sudden episode of fever, and you see that if you take x-rays, you see that there's thickening of bone, extraperiosteal bone formation. You see that they have a C-reactive protein, sedimentation rate is high. Now, these children, with time, it subsides even with no treatment. It's called infantile cortical hyperestosis or Caffey's disease. So it's self-limited. It presents at the age of 1 to 5 months with soft tissue swelling, preosteal bone formation. They have cortical thickening, fever, irritability, and it usually subsides at around the age of 3 years. I have seen recently a case at the age of 5 years, so it does occur at older age. It may be isolated lesion. It might be multiple members of the family may be involved. In sporadic form, the mandible is most commonly involved. In the familial and inherited as autosomal dominant from the tibia is involved, from the tibia. So one has the mandible, the other one, the tibia, more commonly involved. This shows you a patient who has both femurs involved with periosteal reaction and even mandible involved in Caffey's disease or infantile cortical hyperestosis. The pathology, we see an inflammatory process that involves the periosteum and surrounding soft tissues. And with time, the inflammatory reaction subsides, leaving a thickened periosteum and subperiosteal immature lamellar bone. Vascularized fibrous tissue occupies the bone marrow. This is a section done, and you can see the bone formation occurring. They have a thickened cortex and periosteum. Likewise over here. Over here it shows the periosteal and inflammatory changes within the scapula. This is florid periostitis that occurs in this condition. Likewise over here. So the disease may be present at birth. These children are hyper irritable. The presence of a local mass over the mandible or tibia, this may be tender. ASR and alkaline phosphatase are elevated. The clavicles, the ulnar, the scapulae, and ribs may be involved. Multifocal involvement is common, but often asymmetric. This shows you the mandible of a child with the Caffey's disease. They have thickening of the mandible. They have involvement of the clavicle and scapula. And they have a periosteal reaction which forms thickening of bone. You should differentiate it from osteomyelitis, prostaglandin E therapy for cardiac anomalies, child abuse, congenital syphilis, hypervitaminosis A, scurvy, Ewing sarcoma, and metastatic neuroblastoma. Treatment, no known treatment, but you can give steroids to alleviate the acute inflammatory reaction. Non-steroidal anti-inflammatory drugs have also been useful. This shows you a Caffey's disease involving the ulna, showing you it of the mandible, showing you of the tibia, scapular involvement, shown over here. Epiphyseal sclerosis, known as Engelmann's disease. These are conditions that you are asked in exams, these conditions. So don't think that these are not important. I would say Caffey's disease, diaphyseal aclasis, or Engelmann's disease. These are important. Osteopetrosis is also important. Hypervitaminosis A is also important. One of the questions you could be asked, give me the differential diagnosis of osteosclerosis of long bones with involvement of the medullary cavity. This is very important. Engelmann's disease is a family of congenital and probably a hereditary condition. It usually begins during childhood, when the child is noted to have difficulty in walking and has a duck, waddle, and shuffling gait. At times, the limbs may be painful, and the bones commonly involved are the femur and tibia. It starts as a thickening the mid-diaphyseal cortex, and this progresses with time towards the metaphysis. The thickening is subperiosteal tissue to failure of resorption from within, so that the cortex is greatly thickened with eventual impingement on the medullary space, not allowing inadequate space for sufficient hematopoiesis or hematopoiesis. The end result is anemia and hepatosplenomegaly. I would like to correct, it's hematopoiesis, not hemotopoiesis. With time, all long bones of the body become involved, including the flat bones of trunk, skull, and face. The head becomes enlarged with frontal bossing. One may get optic atrophy and deafness due to neural foraminal impingement. Dental caries are frequent. It's somewhat similar to what occurs in Paget's in the adult. You see the bone is erotic, there's no medullary cavity. You should distinguish this from osteopetrosis, hypervitaminosis A. The general musculature is flabby and weak. The genitalia may be underdeveloped. Thoracic kyphosis and lumbar lordosis with deformities have the knee commonly occur. About the knee commonly occur. One should distinguish this condition from hyperphosphatasia, hyperphosphatemia, and Caffey's hyperostosis. This shows you a fusiform enlargement of the mid-tibia in the diaphysis. You can see it over here, right over here. Likewise, over here, you have thickening, uniform involvement of all bones, and there's an active inflammatory reaction. The skull, just as one gets with Paget's disease, is thick, and thank you. Now, let me make a resume. My resume is as such. You have to identify dystrophic dwarfism. You have to distinguish it from achondroplasia. You have to know the basics of certain lesions, like the nail patellar syndrome or Fung's disease, where you get iliac horns. You have to know a bit about Engelmann's disease. For sure, you have to know about Caffey's disease, where you get thickening of bone and it undergoes transient decrease in appearance by the age of 5. The symptoms disappear. You have to know about Marker's disease. You have to know how the child presents with the thick lips, lousy teeth, with platyspondyle. You have to know that these children die at an earlier age and they have a pectus excavatum. At times they have atrophy of the odontoid process. You have to know about Hurlers, where they develop corneal opacity and they die at an earlier age. We know in mucopolysaccharidosis, where you have either heparin sulfate or any form of sulfate, which interferes with the bone growth. You have to know these. These are all very important findings. Multiple epiphyseal dysplasia, you have to know about it. You should distinguish it from avascular necrosis of bone or Legg-Percy's disease. These are the conditions you should know and basic knowledge. Have the highlights. Look in any textbook. Study these, review them, and they will remain in your head. Yani, if you have a patient coming to you and he says, look how smart I am. I can put my shoulders together in front of me. Yes, you should know that it is cleidocranial dysystosis, lack of bony osteoblastic formation, and therefore they have deformities. They have retention of the sutures of the skull. So you have to know these. Khalid. يا خالد.
هذا دكتوري.
ليك
دكتور جون.
بدي اسالك لك شو استفدت من هاللكشر؟
والله يعني فائده عظيمه جدا. اول حاجه هي كونسايز وبتقابلنا حالات كثير، خاصه الاكوندروبليجيا يعني نسبه لا باس بها عندنا هنا، وبقيه الاشياء علشان يسووا ديفرنسز، فالشباب يعني استفادوا جدا.
Very important to know them.
محاضره رائعه جدا.
يعني إذا إجا واحد عنده أوليرز ديزيز لازم يعرفوا إنه من جهة واحدة، لازم يعرفوا إنه there is a possibility of changing to sarcoma. لازم يعرفوا إذا معهم بافوشي syndrome يعني هيمانجيومز. لازم يعرفوا إنه the amount of sarcomatous change is high. These are basics. عدوا دروسهم الليلي. I know they're very difficult. أنا بعرف إنه بالجامعات اللكشر هيدا ما حدا بحب يعطيه، بحولون لعندي لا تعطيه لأن ما لهم جلدتهم. بقول لك إياها these are very important. They are very important to know.
إحنا we record the lecture.
أعطيهم إياها.
أي بعطيهم إياها. وعلى الكلينيكال بيسز بتجي حالات للعيادات ما حدا بعض الأحيان ما يتنبه لهالحالة. إذا مش عارف لهالشيء يعني بتطلع عليها الحالة يعني.
لازم يكون عندهم بيسكس يحطوها بالكلينيك، بس يجي بيشنت يطلعوا بالصور يعني يحطوا صورة واحدة من كل واحدة. بيقدروا يقولوا لهم للأهل، ينبهوا الأهل شو بده يصير بالولد، كيف بده يصير، شو مستنظر منه. اوكي ليك خالد بدي اسالك بتكون يا جمعة الجاية او جمعة اللي بعدها؟
اللي بعدها علشان معانا نشاط احنا
انا I agree with you. اوكي يلي من بعدها
عشان نعطيهم ايوه بين جمعة وجمعة الجمعة اللي وراها
هي اللي وراها. اوكي بنكمل بالبيدياتريك اورثوبيدكس بدي جرب خلصها قريبا لحتى بنرجع نفوت.
واحنا حتى محاضراتنا هنا في المراكز بنخليها على البيدياتريك هالشهرين علشان نمشي معاك.
اوكي very good very good. يلا سلم على الكل. يلا have a good day.
كلهم يسلموا عليك. سلموا على الدكتور.
شكرا دكتور.
يا اهلا. thank you. bye.